Okay, so what we, um, oh, hang on one second. Okay, so when we left off talking about basically how, this is the beginning of how is urine made in the kidney. And this is the microscopic level. Um, but um, this this nephron, like I said, when we cut open a kidney, you're not going to see this. This is microscopic. And this structure, again, is in, if you look at the side, cortex medulla, half of the structure is in the cortex, half is in the medulla. And so let me start by what happens. Now, remember I said the kidney is like a filter. When all of the blood and blood that's circulating through the body is all eventually going to come through the kidney. Now, first of all, when blood comes to the kidney, it's bringing oxygenated blood to the kidney so that the nephrons stay alive. It's got to give oxygen and provide a way for CO2 to be exchanged. But when the blood, think about the fluid and the blood, it's carrying nutrients, wastes, soluble materials, cells, all of that is traveling. And what's going to happen is when blood comes into the renal artery, it's going to branch into an afferent arteriole. Now, afferent is when something is coming in. Do you remember afferent, efferent with the spinal cord? When blood comes in, it's called the afferent arteriole. It comes in. Now, it's lined with these endothelial cells, and those little cells have fenestrations, which are little openings. And when this blood comes in, it's under pressure. It's under blood pressure. And when it enters in the middle of this corpuscle, it enters this middle thing, and this is called the glomerulus. And the glomerulus is basically called a tuft of capillaries. It's like a bundle of capillaries. And remember, capillaries are one cell thick, and this is where things diffuse. So when the blood comes in here, anything that is soluble is going to get pushed out of the blood into this yellow space. And this space, this is the capsular space. So whatever can get pushed out is going to get pushed out. And the product that is in this yellow space, the capsular space, is called glomerular filtrate. You need to know that. So if I ask what is contained within the capsular space, you would tell me glomerular filtrate. Now, this is when the blood is filtered, and this is the first stage of urine production. Glomerular filtrate is eventually going to become urine. So what is, you can think yellow and urine, maybe the yellow color here, and so what gets pushed out? Well, let me give you an analogy, because I don't know, they help me, maybe they help you. If you know what a kitchen strainer is, sometimes you put it in the sink and you go to, so say I just want canned tomatoes. I want diced tomatoes, but I just want the tomatoes, okay? So I pour a can of tomatoes in the strainer. What comes out the bottom of the strainer? What comes out underneath the strainer? If I put it over a bowl, what do I get at the bottom of the bowl? I get the liquid, the juice, right? What stays in the strainer? Or the pieces, the solute. So So I want you to think of this, the glomerulus. Think of this like a strainer, a kitchen strainer. And when the blood comes in, okay, certain things are going to stay in the strainer, which is the blood. Okay, so certain things aren't going to be able to push out of the blood because they're too big. Red blood cells, white blood cells, platelets, proteins. Proteins are too large of a molecule to fit through the strainer or the glomerulus. But what is going to get pushed out? Body water, sodium, potassium, chloride, urea, nitrogen, right? Waste, nutrients and wastes, soluble materials.
Okay.
So when are you going to be back? Okay, I'll text you. Sorry. So if you think of it like a strainer, when I dump a can of tomatoes in a strainer, the juice comes out, which you can think of as soluble, and then what stays in the strainer is like the cells or the big pieces of tomato, which would be like cells and proteins. Okay, now if it doesn't come out in the strainer, which is right here, or the glomerulus, it's going to stay in the blood and go out the efferent arteriole. So the red blood cells, white blood cells, protein, platelets, those things are still, and some body water, okay? That's going to stay and then leave, leave via the efferent arteriole. Now, what I'm talking about now is what's in this capsular space. And that product, which would be my tomato juice, that product is glomerular filtrate. Now, the body at this stage is not specific. It's just going to push out anything that will push out, anything that will filter out, anything that's soluble. Those are good and bad things. So as this glomerular filtrate makes its way through the tubules, the body can reclaim. It might be like, oh, my bad, I didn't want to get rid of that potassium, I want it back. Or the body is going to decide, yep, we don't want that urea, leave it in the tubules, it becomes urine, it leaves the body. So as I'm going to talk about the nephron, that's when I'm going to talk about reabsorption and secretion. Okay, so the product in here is glomerular filtrate. Now, after the glomerular filtrate, it's going to move into this first part of the yellow tube, which is the PCT, proximal convoluted tubule. And it's a continuation of the Bowman's capsule. It's connected. I know it looks like it's closed here, but it's connected. So now the glomerular filtrate is going to move into the tubules, and it's now becoming tubular filtrate. Once it leaves the glomerulus, once it leaves the Bowman's capsule, it now becomes tubular filtrate. Now, at the level of the PCT, this is where secretion and reabsorption are going to occur. So now, once it moves through, the body is now going to decide, do I reclaim it or do I let it go? If I reclaim it, that's reabsorption. And so when I say reabsorption, it's taking something from those tubules and bringing it back into the blood to get carried back into the body. If it's secreted, it's going to stay in those tubules and eventually make it out the collecting duct and make it into the urine. Therefore, it's secreted in the urine. Now, the next part, after it goes through the PCT, it's going to go down this loop of Henle, which the loop of Henle dips down into the medulla. It dips into that middle part of the kidney. This part, it comes down the medulla, it makes a little U-turn, and then it's going to go back up into the cortex. Now, if you look, one side is really thin and narrow, and then it gets thicker. Well, the ascending wall becomes a little bit thicker because it's got to push that stuff up. It's got to push that material, by gravity, it comes down. So that descending loop is thinner than the ascending loop, and it's going to go back down. Now, what is in here is still called tubular filtrate. So right now in the yellow tube is tubular filtrate still. The last part of the tubules is called the DCT, which is the distal convoluted tubule. And it is a continuation. It's going to come around here and loop and loop and loop. The DCTs of every nephron, say there's 200,000 of them, all of those DCTs are going to empty into the collecting ducts. And then all of those collecting ducts, let me go back to a picture. Oops. All of those collecting ducts are going to dump into this renal pelvis. So in this cortex and medulla are all these hundreds of thousands of nephrons. So all of those collecting ducts are dumping into the medulla, which connects to the renal pelvis, and then eventually leaves. Here we go. Which eventually leads into the ureter. Now, if you remember, I'm going to talk a little bit more about this, but I was talking about ADH, which is a common, it's called anti-diuretic hormone. So let me talk about what diuresis or a diuretic means. A lot of people are on diuretics. A diuretic is like a medication that will make you urinate more often. Now, sometimes when people have edema, like fluid buildup in their tissues, and we do this with animals, sometimes if they have pulmonary edema, we give them a drug called Lasix or furosemide. Furosemide or Lasix is a diuretic. When we give that pill, it will force body water, it will pull it from the tissues. It forces body water to be excreted through the kidney. So I always tell owners, and this is just, if an animal's on a diuretic, and this is a tip, I'm like, your dog is potentially going to want to drink more water because we're forcing diuresis, and they're going to urinate more often. So they probably have to go out more often. I mean, people might get mad. Oh my gosh, my dog's having accidents. And, it's not that they got to go. I mean, we're forcing body water. We're diuresing the patient. Now, we can give drugs called diuretics to do that, but the body also maintains fluid balance by this hormone. So the primary site of action, when the brain, the pituitary gland, releases ADH, it has its effect at the kidney. It's either going to tell the kidney to retain body water, reabsorb body water, or it's going to increase secretion of body water. Now, antidiuretic hormone is usually going to be released to conserve body water. So, for example, if the animal's dehydrated, what happens to an animal's urine production when they're dehydrated? Does it increase or decrease? If an animal's dehydrated, do I expect an increase, or it's going to decrease? So the number one thing we look for when an animal's dehydrated is, what is their urine production? It's usually decreased, because when an animal's dehydrated, the body will release ADH, antidiuresis, antidiuretic hormone, and it will tell the kidney, hey, we need that body water back because we don't have enough body water. And hence the animal makes less urine. Hence they urinate less often and they have more concentrated urine. You guys will learn in animal or Clin Lab 3, when you talk about urinalysis, we measure concentration of urine, especially when we're monitoring animals, for urinary problems, but when we're monitoring hydration. But usually when they're dehydrated, their urine is very dark yellow and has a high specific gravity, which means it's very concentrated. If your animal has what's like clearish to very light yellow urine, then it's less concentrated and it typically has a higher concentration of body water. Therefore, it's less concentrated. Now, the reason that ADH works at this DCT is this is the last stop. If you look at this collecting duct, do you notice it doesn't have any blue or red squiggles around it, which are the peritubular capillaries? So once tubular filtrate makes it into this collecting duct, there's no more absorption and secretion. It's leaving. It's now going to become urine. It's pretty much urine by now. So the DCT is it's like, hey, this is the last stop. The body's last chance to reclaim anything from the tubules is at the DCT, because after the DCT, it moves into the collecting duct. After that, the body's SOL, means you're out of luck. it's gone. So I want you guys to remember that. It's like, this is the last stop before the collecting duct, which leaves to become urine. So if the body really wants to reabsorb anything, last chance is at your DCT. And this is where we have ADH action, regulation of potassium. This is the body can either secrete or reabsorb potassium if it needs to, and help with that acid-base balance. So the DCT is kind of an important part because it's the last stop. Now, I want to mention something too, because you might, when you get into pharmacology, I'm going to back up to the loop. There's a group of drugs that we can give patients called loop diuretics. And a diuretic, again, a diuretic is usually forcing water out, making them urinate, making them lose body water. But loop diuretics have their effect at the loop of Henle. That's where they get their name. So they're going to have their effect at the loop of Henle, that group of drugs. So if you hear that term, loop diuretic, it means they're acting at the loop of Henle. So now I'm going to continue to talk about things, but I want you to kind of understand what's happening as stuff is moving, So let me back up a second. When you look at this picture, your blood, red blood cells, white blood cells, platelets, proteins, are pretty much in the bloodstream. Oh, let me bring up I'm going to talk about them. Let me back up a second. So the blood is within these blue and red tubes. Again, the yellow tubes are carrying what is being filtered out of the blood, good and bad, and it goes from glomerular filtrate. When it moves in, then it becomes tubular filtrate. Once it enters the collecting duct, it is now urine. And then again, once it's in the collecting duct, it's leaving. It's urine, it's gone. So at that point, the body can't really reclaim things that it wants to. Too late. Okay, now nerve supply to the kidney, if you remember, and this is part of the autonomic nervous system. So you've got, the kidney is going to function. It doesn't necessarily need a nerve supply. But when the animal is in sympathetic stimulation, if you remember fight and flight, I said that all smooth muscle kind of innervation is slowed down. Smooth muscles control the vessels to the kidney. So what happens at the kidney? Those vessels are vasoconstricted because that blood, in sympathetic stimulation, that blood is needed elsewhere. The kidneys, the digestive system, they're all kind of on the back burner. So when that blood supply is diverted from the kidney to the other organs, that in effect decreases urine function. So while an animal is in sympathetic stimulation, we have a decrease of blood flow to the kidney that decreases urine production. Now, when the animal is rest and relax, parasympathetic stimulation, the blood flow is reestablished, urine production will resume. Now, I've told you guys before, I've talked a little bit about blood pressure, and I said when I talked about systolic, diastolic, and mean blood pressure, and I just did this last week with my anesthesia class. When we do blood pressure measurements, the mean, which is the number off to the side, which is the average, we don't want it to drop below 60 as a value, because what happens when blood pressure is getting to 60 or lower, then what's going to happen is blood is sent to other organs, and then we lose perfusion to the kidney. So number one, the kidney's not going to get as much oxygenated blood flow, and it's going to temporarily decrease urine production. And urine production is how we get rid of wastes. So that's a very important concept to understand, is that, blood pressure and kidney perfusion is essential to get rid of waste and to maintain the health of the kidney. Now, I've talked about blood flow so many different times, but let me review here. So the blood supply to the kidney, anything kidney is renal. So the renal artery branches off of the aorta. So the descending aorta, when the aorta leaves the heart, it splits into what's called an ascending and descending aorta. I think on all your test questions, I just said aorta, but it splits to the front half and the bottom half of the body. The descending aorta is going to branch to the renal artery. And when the renal artery comes in, it has to subdivide. Because remember, each nephron needs arterial blood flow. So if you look in this picture, here's a renal artery. Here's it branching into a renal arteriole. Then it's going to come up here. And when it comes in, it's going to come into an afferent arteriole, comes in the glomerulus, filters its blood. Blood is going to stay in the arteriole. It becomes an efferent arteriole. Efferent leaves. Afferent comes in, efferent leaves. The efferent arteriole is then going to branch into the peritubular capillaries. Now, that's what these are, these little string-like structures. So the peritubular, around tubular, tubules. The peritubular capillaries surround the PCT, the loop, and the DCT. Now, what do? Number one, they give the nephron oxygen. So they bring oxygen. They pick up CO2. But the other thing they do is they can reabsorb materials that were in the tubules that need to get brought back into the blood. So that's what I'm going to talk about. Okay, so an afferent glomerular arteriole carries blood into this capsule. The glomerular capillaries in here are going to filter out the plasma. So the plasma is the water component of the blood. So some of that plasma gets pushed out. And again, things that are soluble are in the plasma, not only body water, but other components. All right. And that's the glomerular filtrate. Then the peritubular capillaries are going to come down here, surround the tubules, and then we can have reabsorption and secretion. So tubular reabsorption, tubular secretion occur in the peritubular capillaries. That'll be important for the test. Because I'm like, where does reabsorption take place? In the peritubular capillaries. How does oxygenation take place? In the peritubular capillaries. Well, you guys should know that from your blood flow that I've done 3 times now. Remember I said aorta, artery, arterial, capillary, O2 for CO2? That's the peritubular capillaries that are doing that. And then that CO2 goes from the peritubular capillaries to a renal venule, which is right here, to the renal vein, and then the renal vein is going to leave the kidney and hook up with the vena cava. So that's the blood flow. I mean, that's, since we've been doing that, that's what I'm explaining. So what happens inside the kidney? So first of all, it filters all the blood. So we have to have filtering, and then it's going to reabsorb things that are good, things that are useful. Because again, when it gets pushed out in that glomerulus, again, good and bad gets pushed out. It's non-specific. So as the blood goes through the tubules, the body's like, whoa, wait, I want that back. I want that back. Or sometimes things that didn't get pushed out can still be secreted. What if there was like an oopsie? The blood, some of the wastes made it back into the peritubular capillaries. Well, the blood can still secrete from the capillaries into those tubules. The most of the filtration occurs in the glomerulus. But as the capillaries surround the tubules, things can still go back and forth. So I just want you to understand, it still can go back and forth. So the main location that blood is filtered is in the renal corpuscle, that circle. In the corpuscle, you have a glomerulus, that's the filter or the strainer. You have the capsular space, and in that space, that's where the filtrate is. It's kind of like, that's kind of like the bowl under the strainer. If you think about my tomato analogy, you know, you put the strainer on a bowl, and you know, because I want to save the tomato juice. So when I dump the can of tomatoes, or the blood comes in the glomerulus, what gets pushed out is the juice, and I have a bowl to hold it. And then what stays in the strainer is in effect what goes back into the efferent arteriole, which eventually turns into a peritubular capillary. Now, inside that glomerulus, or that filter, the blood is coming in under blood pressure or high pressure. And that is what allows the plasma to get pushed through. Blood pressure forces plasma out through the fenestrations, and then you get, you know, the capillary. Now, remember, endothelium is the lining of the capillary. Endothelium is the lining of any vessel. So inside those capillaries are tiny little fenestrations, which are like little holes. And it allows the plasma and soluble products. It's like the holes in a strainer. What comes out in the glomerular filtrate is all those soluble products, but we should not get protein. Okay, this is important. You guys got to follow me here. Hopefully you're not getting tired. What gets pushed out is glomerular filtrate, but it should not contain protein. Now remember, glomerular filtrate is eventually going to become urine. So, for example, you have to hear me here. I just did a urine on my cat. I did a urinalysis, and I did it was a cystocentesis, and I was just really wanting to make sure his urine was concentrated because he's an old cat. I was concerned about his kidneys. When you guys do a urinalysis, you do a dipstick. It's like a little stick with the different colors on the stick. You put the urine on it, and you're testing for chemicals in the urine. One thing we test for is protein. And on a urinalysis on a healthy animal, you should get a negative protein. We don't expect protein in the urine because protein should stay within the plasma, right? It doesn't get filtered. So what happens when you get a positive protein on a urine? Well, my cat had 2+ protein. You know, based on the color change, it gives you an idea of how much protein is in there. I think the highest is 4+. There's like trace, 1+, 2+, 3, maybe 3 or 4+. So he had 2+ protein, but I will give you a little tip. He had cells in his urine. He had transitional cells, white blood cells, and red blood cells, because we're kind of treating him for a UTI. So sometimes when you have cells in the urine, it will cause a false positive protein. And when I did the sediment, I confirmed that. I did a urine sed. I looked at the urine on the microscope. There was lots of cells. So that's probably why he had positive protein. But for example, if you did a urine, got positive protein, and then you looked at a slide and there was not really any cells, then that's probably true protein in the urine. And you guys will learn all this in your urinalysis. But the reason I'm bringing this up is that occasionally, in high blood pressure, well, let me talk about what's called glomerular filtration rate, or GFR. GFR is the rate of filtrate production. So in a normal animal that has normal blood pressure, you expect a normal GFR. But the GFR depends on the blood flow to the kidney. Let's talk about an animal with high blood pressure. And sometimes cats organically have high blood pressure. They're hypertensive. Now, if you think about my strainer, okay? This is going to make sense, I promise. I dump a can of tomatoes in the strainer. I get tomato juice underneath. What do you think will happen if I push on those tomatoes in the strainer? If I put pressure on the tomatoes, what do you think I'm going to do to the juice underneath? A couple of things I'm thinking of. If I push on those tomatoes in the strainer, what do you think is going to happen? I'm going to make it go faster. Some solids are going to get through. I'm going to increase the filtration. So first of all, I'm going to make probably more juice. I'm probably going to get more tomato juice, right? So I'm going to increase production. It's going to be faster, but probably in the process, little bits of those tomatoes, which normally would not fit, are going to get through into my juice. Excellent answers, guys. Exactly what I was looking for. So if I have an animal with high blood pressure, that means the pressure coming into the glomerulus is under high pressure. What can happen is, first of all, you're going to increase rate of GFR. So you're going to increase filtrate, could increase urine production. But I also might get things in the urine that get pushed through accidentally, like protein. Because normally protein wouldn't fit, but if the blood's like, if the blood's pushing through and some of those proteins pop through, sometimes it can be related to GFR and blood pressure. So, again, protein, if we do a urine and we have protein, we have to figure out why. Now, like I said, this just happened to me. When I got protein on his dipstick, I was like, wait a minute, why does he have protein in his urine? And then I was like, and then when I saw the cells, I'm like, that's probably why. Probably next I would have done a blood pressure on him to check his blood pressure. But when he had the cells, I'm like, the cells can cause a false. Sometimes if you have someone that's doing a heavy protein diet, there's a possibility, but that's rare. So unless you know someone's really blasting their animal with protein, potentially. But these are just things, this is understanding that blood coming in there is, if it's under normal blood pressure, we expect a normal rate of GFR, normal filtrate production, and we only expect certain components to be in that filtrate. But it's when that gets increased, if we're under pressure and we're putting a lot of pressure on that glomerulus, and then we're increasing GFR, increasing production, and then potentially getting things through, that could be, because again, what's in the filtrate is eventually going to be in your urine sample. So now normally when you do a UA, you look at a urine and you're only kind of thinking maybe of the bladder, but the urine has come from the kidneys, which filtered blood from the body. A urinalysis is kind of like a window to the body, because you're going to test for glucose, bilirubin, protein, leukocytes, red blood cells, uric acid is on. I mean, there's various chemicals that we screen on a urine, and we look for, and again, there's appropriate numbers of certain things we don't expect to find. Glucose. We don't expect glucose in the urine unless they have a severely elevated blood sugar. And then if we get a positive glucose on a urine, the estimation is that their blood glucose is higher than 300, because that's kind of like what's called the renal threshold. It takes a blood glucose level of 300 for it to start to spill in the urine. So it's very significant to find glucose in a urine. Then that means in the blood, you're at least 300 or more. So you'll learn all that when you talk about urinalysis. But I want to stop there because this is an important part, and let's just kind of digest that for today. And you guys can kind of wrap your brain around that part of the nephron. So are there any questions about, I'm going to get into some of the things that are reabsorbed and secreted, and that's coming up here in these next few lectures. So that will be coming up.